بسم الله الرحمن الرحيم. السلام عليكم جميعا. I will try in this video to make imaging to be very simple. I will start here by orthopedic. Orthopedic imaging. Okay. Number one. X-ray. This initial investigation for trauma. Fracture or dislocation. Okay. First thing you will do X-ray. Number two, CT. This for best investigation. There is difference between best and initial investigations for fracture. Number two, missed or unclear fracture. Number three, intra-articular. Number four, complex supracondylar. Fracture calcaneus for more detail. Fracture scaphoid not clear in X-ray. Number three, MRI. Soft tissue edema. MRI for knee ligamental tear, not fracture, ligaments. For back, for disc, especially patient with neurological manifestations. Okay. Don't do for back except with neurological manifestations. For the spine, yani back or spine in general. Okay. Joint for ligaments and capsule soft tissue. Okay. Lastly, like scaphoid, early for soft tissue edema. Number four, bone scan. Bone scan. This for bone metas for births can be used for births. Okay, births disease can be used. Okay, this imaging of orthopedic. Imaging for orthopedic. Now, I will come for another thing in orthopedic. Another topic for orthopedic, which is back pain. Back pain. Okay. Initially, X-ray. Traumatic, CT. Plus CUDA, equina, or neurological manifestations, MRI. A, B, C, D. Signs of metas bone scan. This number one. Number two, scaphoid. Asking for missed fracture, CT. After edema subside. Asking for soft tissue edema or within 24 hours, MRI. Facial fracture. Please, for concentrate about this point. Don't do MRI. Don't do MRI except you have neurological manifestations. If you haven't, no need. Facial fracture. Facial fracture. The ideal for facial fracture, initial X-ray. Best 3D CT. Diplopia, or looking for muscles, ocular muscles, MRI. Okay, this all for orthopedic. Next topic, vascular. Okay, next imaging about vascular, arterial. Initially, arterial claudication. Arterial claudication or ischemia. Okay, initially, hand Doppler. Hand Doppler. Okay. In hand Doppler, in arterial, I will measure, I will look for pulse and A, B, B, I. Okay, this number one. Go through this sequence. Number two, duplex. arterial, and here is venous duplex. So this is initially. Venous duplex, okay? Then the golden standard for venous is venography. Golden standard. This is how to go. Patient with varicose vein, hand Doppler, then venous duplex. Asking for the golden standard venography. Type for arterial. Arterial duplex. Arterial duplex. If patient number 3 planned for surgery, according to the finding in arterial duplex, I will go for CT angio or MR angio. Renal impairment. If renal impairment, don't do CT angio. Okay. You have another options in arterial. Number 4, arteriography. This not done, يعني not done because this is invasive technique. This invasive. So this diagnostic and therapeutic. Any you want any artery, you want to diagnose it, CT angio. This what, where is any artery in bowel. Okay, whatever the condition. Okay, this is how to do vascular imaging. Renal imaging. Number 1, ultrasound. This for stone or mass or pelvic examination in young girls, pregnant young children. Number 2, CT. CT is the golden standard for CT, plain CT, by the way. CT is golden standard for renal mass or stone. Okay, renal mass or stone. Number renal mass, even tumor, okay. Number 3, DAMSA scan. DAMSA scan, this is secreted by the kidney. Secreted by kidney. DAMSA scan used mainly for BUJ obstruction, by ectopic cortical defects, ectopic or cortical defect. Not used in patient with impairment, renal impairment. Okay. Number 4, DTPA. Used in assess glomerular filtration rate. Sorry, this one can't be used in G. Assess glomerular filtration rate. Imaging, not like clearance and urine clearance. Okay, and urine clearance is investigation, but this is imaging. Okay, so this is another thing for glomerular filtration rate. Renogram, one of the important imaging. Number 4. Number 5. Renogram or mag renogram, mag 3. Mag 3 renogram. Okay. This assess kidney, failing kidney. Assess failing transplanted kidney. Plus, if diagnosed BUG obstruction by CT, not by ultrasound, don't go for DAMSA. Don't go for DAMSA. Go directly for renogram. Okay. Number 6. Cystourethrogram. First, I will give the condition for it. Cystourethrogram can be used in many conditions. Number 1, structure. Number 2, vesico-ureteric reflux. Vesico-ureteric reflux, patient will come with pain. Remember this word, on voiding. Okay. Plus bladder and urethral injuries. Okay, bladder or urethral injuries. Ureterogram or cystourethrogram, this is very important. Antegrade and retrograde came last exam. Okay, retrograde means that the contrast, retrograde, contrast injected through urethra, from urethra. This is a dye from urethra. Antegrade, from bladder. Or from above, yeah, from above. Okay. So what is the indication for everyone? Antegrade and the retrograde. This came last exam, by the way. So antegrade, filling the bladder with contrast through urethral catheter or by percutaneous needle of the bladder. So this ideal for examination of the bladder. So this is ideal for the bladder, like bladder injury. Okay. While retrograde, this is straightforward, by the way, and the very easy and the cost-effective examination. And this is for patient with urethral injury or stricture. Any problem in urethra? Simply urethral injury or strictures. So if I will ask you about a stricture, this one, what is the ideal is retrograde urethrogram. Because last exam coming about retrograde and antegrade, this is simply what is this and what is this. Okay. Finished from renal. I will go for next. Thyroid, number 1, ultrasound, nothing else. Number 2, this is how to diagnose any lesion in thyroid. Number 2, file needle aspiration cytology. Okay. If inconclusive, I will go for biopsy. Hemithyroidectomy. This for thyroid condition. Now I will come for breast imaging. Number 1, ultrasound. Ultrasound for age more than 40. Less, not more. Less than 40 years. Okay. Number 2, for any lump, any breast lump. Number 2, mammography. For male breast and for women more than 40. Okay. Number 3, MRI. Indication of MRI in breast. Number 1, lesion not confirmed by previous imaging. يعني lesion not confirmed by ultrasound or mammo. Okay. Number 2, lump over scar of mastectomy. Number 3, rupture implant. Number 4, lump over implant in high risk patient. Okay. So for implant, we have 3 conditions. Number 1, follow up. Number 2, rupture. Number 3, lump over implant. If follow up only, ultrasound. If rupture, MRI. If lump over implant, normal person or high risk. Okay. Normal or high risk. Normal person, sorry, again because of interruption. So implant only. If follow up, I will do ultrasound. If rupture implant, I will go for MRI. If lump over implant, I will look for 2. If normal person or high risk person. Normal and the high risk. Okay. Normal, I will continue by ultrasound, while patient high risk, like positive family history, BRCA1, all high risk patient, I will go for MRI. This came in exam. This is the question of the exam. Okay. This for imaging of the breast. For biopsy discussed already in breast lecture, by the way. But I will finish. خلاص بقى تاخدها بجميله معاكم. I will finish now. Also for breast biopsy. It will be in the next page. Okay. Breast biopsy. Number one, file needle aspiration cytology. File needle aspiration cytology. This for cystic lesion and lymph node. For cystic lesion and lymph node. Cystic lesion only or lymph node. Axillary lymph node. Okay. After taking fine needle aspiration from cystic lymph node, cystic lesion, I will go for cytology. Okay. Cytology. If negative, discharge. If positive or recurrent cyst, I will go for biopsy, not biopsy. Okay. Number two, excisional biopsy. Excisional biopsy for fibroadenoma. Number three, core biopsy or trocat. For any lump, especially suspected cancer mass, after doing imaging, you will go for biopsy. You will go for fine needle only for cystic. So after imaging for any lump except cystic, especially if suspected malignancy. Okay. Number four, is stereo. Number four, if stereotype core biopsy. Okay, this in micro classification. This especially key in exam, micro calcification. Okay, in micro calcification, this biopsy is taking under imaging, under mammography, and for micro classification, if not an option, and if micro classification and if not in option, this one, if this is not option, go for MRI. Okay, this breast imaging and biopsy. Last topic, GIT. Last imaging already done by BNS. She wrote after me. So investigations of GIT. Erect chest X-ray for perforated viscous. Erect chest X-ray for perforated viscous. Supine abdominal X-ray for intestinal obstruction. Initial investigations for any patient, air under diaphragm or perforated viscous by erect chest, not abdomen, erect chest X-ray. What I am telling you now is very important in the exam. Again, suspected perforated duodenal ulcer, suspected air under diaphragm. What is the initial investigations? Erect chest X-ray, patient with dilated loop or air fluid level in abdomen or signs of intestinal obstruction. What is the initial investigation? X-ray abdomen. Ultrasound in abdomen or GIT for any collection like abscess, for gallbladder especially, thickening of the wall, polycystic fluid collection, which means acute inflammation. Also, you look for intra or extrahepatic biliary dilatation. Okay. If you will find the intra or extrahepatic dilatation, to finish from it, and if you will find the dilatation, you will go for ERCP. If ERCP fail, I will go for percutaneous PTC. So dilatation by ultrasound, ERCP or MRCP. If this fail, I will go for PTC. this for Berry system. Okay. For pancreatic necrosis, hydatid cyst, colonic abscess, staging and grading, you will go for CT scan. CT with contrast for traumatic. Listen to me. CT with contrast for any perforation, any trauma. يعني like patient with perforated viscus, this initial based CT with contrast. Patient with intestinal obstruction, so based CT with contrast. Patient with trauma RTA, CT with contrast. MRI for liver lesions, especially for metas. Enema, you have water soluble orgastrographine for any acute attack, perforation, acute attack, diverticulitis, inflammation, all this. If you wanted to go for enema, and by the way, the best by the way for any perforation is CT. Is the best by the way, if you want. But if you're asking about the enema, water soluble orgastrographine or barium enema for any acute attack, perforation, or acute diverticulitis, I will go for water soluble orgastrographine. Barium enema, barium is irritant, can cause peritonitis. So this is for fistula, uncomplicated fistula. The uncomplicated patient has no signs of inflammation, can go for barium enema. Fluorosis is for small bowel. Patient with hematemesis, I will go for upper GI endoscopy. If patient has melena, I can go for lower also. If patient has melena, forget this. I will go for lower also. I am telling you now about upper GI, upper GI endoscopy. This for hematemesis. Come for the lower, rectal bleeding. Initially or in the clinic, I will go for sigmoidoscopy. Also, sigmoidoscopy is ideal for patient with hemorrhoid. And is the best for hemorrhoid. But patient with rectal, hemorrhoid can come with rectal bleeding. So in the scenario, if you can see in the scenario that patient has signs of hemorrhoid, you can go for sigmoidoscopy or in the clinic. But if rectal bleeding due to malignancy or suspected malignancy, colonoscopy. But if patient has rectal bleeding and I found upper GI endoscopy and colonoscopy negative, I will go for angiodysplasia. Sorry, I will go for angiography. Angiography for angiodysplasia. What is the rule of angiography? When you are doing upper GI endoscopy and colonoscopy negative, and the patient has massive rectal bleeding, I will go for angiography. Plus vascular causes, patient has any signs of mesenteric ischemia, CT angio for arterial causes like I discussed already in vascular. I wanted to tell another 2 points. Regarding any cancer. Okay. Number 1, diagnose the cancer first. For any cancer. How to diagnose cancer. Okay. Number 1, diagnosis by CT or MRI, like neck tumor. Like, give me example for it. Pharynx, larynx, whatever, neck tumor. Okay. After diagnosis of the cancer, you will go for next step, which is beta scan or CT, chest, abdomen, and pelvis. After diagnosis, if mentioned in the scenarios that patient diagnosed already, you will go for this investigation, this for staging and grading. Look for the scenario. If suspected cancer, you can go for CT or MRI to diagnose it first, or according to the modality for every. But if diagnosed, you wanted to do staging, you will go for beta scan or CT chest, abdomen, and the pelvis. This is coming every exam. Last one, this is coming every exam. Okay. I hope all imaging are clear. I tried to collect all from my mind. Wallah, I'm not preparing. I'm trying to collect all from my mind. I hope it's clear for all of you. I think this is one of the treasures in this course. Thank you.